Thank you. Good afternoon, everyone. Really looking forward to discussing ambulatory outpatient stewardship with you. It's kind of the frontier that has not been tackled aggressively, especially not aggressively, to date. So we have a lot of opportunity to make a lot of headway there. All right, hopefully they can hear me online. I'm going to set the microphone down. But I have no financial relationships, so nothing to disclose here. My objectives are pretty straightforward. I want to go through how to set up an antimicrobial stewardship program in the outpatient space, and also what are some actionable items that you can take or your stewardship outpatient teams can take to be effective in driving practices and reducing antimicrobial prescribing outpatient. Now, I do want to take a poll of the group here. And am I supposed to be able to see my slides on here or no?
I think we can arrange it if you need.
It's okay. I can just kind of look back here. But
Hey, let's see. The gentleman did say not to touch this,
I
but
know.
I'm going to.
There we go.
Are we good?
It seems to still work. Okay, perfect. Thank you. All right. So just to poll of the audience, does your outpatient medical group have an active antimicrobial stewardship program right now? Nobody does, maybe sort of. Okay, that's kind of what I thought. We've convened a large group of healthcare systems over the last couple of years at ID Week, and we've continued to meet regularly just to discuss stewardship in general within healthcare systems, and that's the general consensus. Most of our systems, which are typically ahead of the curve, do not have ambulatory services for antimicrobial stewardship. So what do you believe is the major barrier or even multiple barriers that are competing with standing up stewardship programs in the outpatient space? So raise a hands. Is it resources? Yep, probably resources. Leadership support? Yep. Clinical champions? Yep. Patient population? Yep. Technology, they're all there, right? So there's lots of different competing factors that are at play that are maybe inhibiting us from moving forward and making it difficult with standing up stewardship outpatient, where we know stewardship has really long time been in play in the inpatient setting. So I just want to start off with saying I was preparing for this presentation a month or two ago, knowing that the core elements from the CDC for outpatient stewardship were going to be released here in 2026, focusing this presentation on the fact that I kind of knew what was coming, but the core elements were not quite out yet. They were released this week. So excellent timing with this presentation. The outline of the presentation will still follow the old core elements, but I have some very key action items that will apply really to the new core elements, focusing on the broader health system, leveraging of your resources within the system to improve stewardship across the continuum of care. So here is just a nice graphic showing you how many antibiotics are prescribed in the outpatient space compared to the inpatient space. We know that broad spectrum antibiotics are probably used more commonly inpatient, but the vast majority, 80 to 90% of antibiotics are prescribed outpatient. And of those, we know that somewhere between 1 out of 6 or even 1 out of 3 of those antibiotics are inappropriate. So we have a lot of opportunity. We've been focusing all of our efforts on the inpatient space, but we really need to look outpatient. Otherwise, we're not going to move the dial with resistance. Some more stats, and I know I'm preaching to the choir here because we're all stewards in this conference, but roughly every year, about 7 in 10 patients receive an antibiotic. I've even seen numbers up to 5 out of 6. 60% of antibiotic-related costs come from the ambulatory space, and 143,000 emergency department visits each year are associated with adverse drug reactions from antibiotics. So it's not just the resistance that we're worried about, it's people coming to the hospital having had an adverse drug reaction to an antibiotic or to any drug that they've been exposed to, really. And in the outpatient space, where we used to think of C. diff being primarily inpatient associated, you're in the hospital, you got a broad spectrum antibiotic, we're seeing more patients come in from the outpatient setting now with C. diff. And we have been able to predict that if we reduced antibiotic prescribing outpatient by 10%, we could reduce C. diff rates in the outpatient setting by 17%. And here are some graphic depictions of ADRs. We probably know all of these. Nausea and vomiting, maybe ADRs in pregnant patients, Achilles tendon rupture, patients on fluoroquinolones, or even Stevens-Johnson syndrome. Now, these are the most severe, but we know that antibiotics are not benign. No antibiotic, no drug is benign. So if we can avoid giving an antibiotic to a patient, or even avoid giving a broad spectrum antibiotic to a patient, hopefully we can mitigate risk. I don't want to spend too much time on the pandemic, but I do think this is very important related to what happened and the ramifications of our poor stewardship during the several years that we were dealing with the COVID-19 virus. The CDC had identified antimicrobial resistance as a major health concern in 2013, and they started to sound the alarm. They created the core elements. They ensured that the Joint Commission required that hospitals had ambulatory or antimicrobial stewardship programs, then scaling to broader settings, long-term care, critical access hospitals, outpatient, now departments of health. And over the course of those several years of prioritizing antimicrobial resistance as a major health concern, we saw a major reduction in antimicrobial resistant associated effects. So deaths from AR decreased by 18%, hospital deaths from AR by 30%, and then the pandemic hit in 2019. And unfortunately, during that time frame, stewardship went out the window. There were other priorities at play, and AR drastically increased again, almost back to where it was prior to us even prioritizing stewardship back in 2013. And hospital-acquired infections and deaths from AR increased by 15% again. So we were very much detrimented from a stewardship standpoint during the pandemic. This is actually from the CDC's report out in 2022 of our high concerned pathogens, multi-drug resistant pathogens. And looking at all of the purple kind of boxes, this is the increase that you see with every single one of these bugs since the prior report. So massive, massive increases in antimicrobial resistant infections, leading to us having to use broader spectrum agents, which just further potentiates the problem. Additionally, probably equally as scary, is we've always been concerned about carbapenem-resistant organisms and having to use our niche anti-gram-negative agents for those specific pathogens. Now, up until recently, KPCs, Klebsiella pneumonia carbapenemase producers, were our primary concern. And we could use maybe something like ceftazidime avibactam, meropenem vaporbactam for those bugs. Well, the metallo-beta-lactamases have really surged in the United States, especially in what you're looking at here. The top line, I know it's kind of small, our KPCs have remained high, but our New Delhi metallo-beta-lactamases over the last couple of years, especially since the pandemic, are essentially at the same prevalence rate as KPCs now. Meaning we have to reach to aztreonam avibactam, maybe cefiderocol, nasty newer drugs that we really would like to hold off on using, but now are kind of forced to use. This is overall antibiotic utilization for all classes in the outpatient space, year after year after year. We're not reducing our use. You can see that in 2020, we had less antibiotics used, probably because the majority of patients were infected with the virus. But then since then, we've continued to see a kind of consistent increase in utilization. And when stratified by gender, women get more antibiotics than men, probably from the UTI spectrum of things. But over time, each gender has seen an increase from year to year to year in antibiotic prescribing. So we're doing as much as we can right now in the inpatient space. Outpatient space, it's just continuing to deteriorate. And so we have a lot of opportunity to address stewardship in the ambulatory setting. Okay, this is a slide that is now outdated, but these were the previous core elements. There were 4, there are now 7. And really the new stewardship, the core elements for outpatient stewardship are focused on leveraging your healthcare system's resources and leadership commitment and technology resources to focus on improving the entire outpatient space. So that's going to be all of your clinics, pediatric hospitals, even specialty and dentistry. There is recommendations for really all areas in the outpatient setting where an antibiotic may be prescribed. So these were necessary updates. And unfortunately, again, I don't have them in my slides, but some of the items that we'll talk about today really will be applicable to the new core elements. So back in 2020, the Pew Trust did an analysis of outpatient clinics and outpatient providers. And I always like to quote this evaluation and analysis because it was pretty shocking what they identified. They interviewed many different clinicians and they determined that 60% of them feel like they prescribe antibiotics better than their peers. 60%. And so that means that we probably have a lot of education and data mining and presentation. This is all outpatient. And we really need to do some convincing of our outpatient clinicians that stewardship's important even in your setting, and you may be the problem. So in the outpatient space, who can contribute to antimicrobial stewardship? We have pharmacists, we have physicians, we have APPs, we have nurses, we have MAs, quality leaders, some infection preventionists. It's really the responsibility of all of those individuals to drive this forward. It's going to be really hard for one person to be preaching to their peers if they're not going to be listening or trying to join in as their rallying army. So the next few sections are broken out by the previous four core elements, but like I said, we'll go into a couple things that are very actionable and some examples from my organization. When you are discussing antimicrobial stewardship with your leaders, if you're trying to garner commitment from your CMOs, your CCOs, your medical directors, pharmacy leaders, there are a couple things that you really need to bring to the forefront of their attention. We know that leaders oftentimes have different priorities than you as the clinical folk trying to drive practice in the right direction, just based off of clinical priorities. There may be healthcare burden. Can we prevent people from having to go to the hospital? Can we reduce encounters in the emergency department? There are economic costs. So the amount of dollars that are spent on niche gram-negative agents are significantly higher than if you're able to give patients ceftriaxone, right? And then there are patient perspectives. The clinicians nowadays are all measured, inpatient and outpatient, on patient satisfaction and their HCAP scores or their post-visit surveys. And oftentimes in the outpatient space, that drives practice. If a patient comes in thinking they're going to need an antibiotic and they should have an antibiotic prescribed by the time they leave their encounter, then oftentimes they leave with an antibiotic prescribed for them. So we want to make sure that we are level setting with our clinicians on how to avoid detrimenting their patient satisfaction scores, but also level set with our patients so that they understand what to expect when they're coming in and they still feel satisfied when they leave the encounter. So when you are working to obtain commitment from your leaders, it's important to, again, understand their priorities, but also understand what role they play in the stewardship program. It's not just signing off saying, yeah, we want you to have a stewardship program, go forth. This person or the individuals that are your leaders that need to commit to this will need to commit time, resources, and they need to commit people to the stewardship programs in order for it to be effective. Additionally, they need to help you prioritize with your peers. So whether they say you or somebody else are the champions of the stewardship program, they need to also be a voice of the matter and have you present at meetings and be able to say, this is a priority for the organization. I've committed to this and we're going to drive this forward. So here on this slide are a list of priorities that maybe your C-suite are thinking about every day that you can sync up with when you have these discussions. Thinking about regulatory compliance. The Joint Commission actually does require that outpatient clinics that are registered under the Joint Commission have stewardship programs. So they may audit you for that. There are other regulatory requirements as well that are at the expectation that HOPDs have stewardship programs. Additionally, present a realistic financial plan. You don't want to go and ask for something that's unrealistic. You don't want to ask for a full-time FTE if that is not what will be effective in a stewardship program. You need to develop a plan that shows that you're going to save dollars in one way or another, and be able to speak to that. How is that going to play out when you are given the resources needed to stand up this program? Additionally, I do just want to share, and we'll go into this in just a couple slides, that stewardship programs in the outpatient space are also a priority from the payers. So payers have penalty programs or saving programs related to reducing antibiotic prescribing for mostly upper respiratory tract infections. So leveraging that and being able to show that your organization is committed to stewardship by reducing antibiotic prescribing, for example, for strep or for URIs and bronchitis, those are factored into payers' decisions on what they'll penalize you for or even potential savings. Showcase the tiered implementation approach. You need to be able to show how you're going to do this. You need to go to the C-suite and say, okay, we're going to hire a pharmacist that has a half FTE per week to focus on audit and feedback. Or what types of interventions are you going to roll out? And what is the timeline for this? Connect to the broader hospital goals, like these that we're mentioning here, and building your own credibility. You may go, and I actually had a slide on this in a prior presentation, you may go to your C-suite, and the first time you present a proposal, they may say no. But then the next time you go, they may say, okay, we'll consider that. And the third time, you've kind of built your credibility. They know who you are. They understand that you are somebody that they should trust and put their resources toward. And by that third time, hopefully you get their approval to move forward. Call out to the 2026 core elements here. We knew they were coming, but hadn't included them in this presentation. Now, this is an example of a commitment document that my organization has put together. This is specifically for the inpatient space, but you can do this for the outpatient space as well. We created a core elements commitment to the program document that our chief clinical officers in each of our markets, which we at Ascension have 9 different markets, which are states. These are encompassing several thousand clinics. Our CCOs will sign off saying that each of the core elements we commit to, and we will ensure that you have the resources and personnel to support standing this up. So that's one way to ensure that you get that commitment, and then holding your leadership to that is kind of the next step. The next core element was action for policy and practice. Now, this really in a nutshell is, what are you going to do? How are you going to address stewardship in the outpatient space? What initiatives are you going to roll out? How are you going to intervene with the clinicians or the prescribers? So the best way to do this is to determine who will lead the stewardship program. Not everyone has an ID physician that's going to be able to take this on in the outpatient space. Not everyone has a pharmacist or even a physician that wants to take it on. It may be a nurse, it may be an APP. So who's going to lead this, and what are they capable of achieving? What is their current knowledge and scope able to implement? Identify the need. So you don't want to just go out there and intervene on something that you don't know is going right or wrong. So you need data to be able to back what you are going to take action on. Are you having an issue with fluoroquinolone prescribing for UTIs? Are you having an issue with prescribing antibiotics for acute bronchitis, which is a viral infection? So identifying where your areas for opportunity are going to be very important. And then select an evidence-based strategy. Don't recreate the wheel. There's lots of data out there for how to intervene in the outpatient space. It's mounting. We had data in the inpatient space. Obviously, that's very robust. Outpatient is continuing to emerge. And there are some very strong strategies that you can implement to really drive things forward without having to recreate the wheel. Here are some examples of what you could implement in your outpatient ambulatory clinics. Some of these you may recognize from the inpatient space, like prospective audit and feedback or computerized order entry sets. But we're not going to go into all of them today. This is just for your reference. I do have some outpatient ambulatory data that I do want to share with you guys, though, on the next 4 slides related to several of these interventions. Prospective audit and feedback is one that we have had employed in most of our hospitals for years, right? We, as the AMS pharmacists, antimicrobial clinicians, have been reviewing antibiotics for quite some time and providing real-time feedback to clinicians recommending to de-escalate or discontinue antibiotics, modify antibiotics. It requires many man hours to be able to do this effectively, but it is real time. So that is one of the benefits here. Now, there was a primary care pilot where they did do prospective audit and feedback for patients that were being treated for urinary tract infections. And they had an ambulatory pharmacist that was deployed just 1/2 day per week to provide prospective audit and feedback. And even with that little amount of this pharmacist intervening, they saw asymptomatic bacteriuria treatment decrease from 25% to 2.6%. So huge, huge improvements in this great opportunity area, but it only took a little bit of effort in prospective audit and feedback from 1/2 a day per week pharmacist. Personalized provider feedback. So this is just educating clinicians really based off of either initial discussions or based off of data showing that they're high opportunity clinicians compared to their peers. And the difference here is that this is not as real time. You're not providing that prospective audit and feedback as you identify an opportunity with their prescribing. You're not telling them, hey, don't prescribe this antibiotic for this patient here. It's more of a higher level education based off of the opportunity identified. So it's not real time, but it does require less day-to-day effort. There was a study in a pediatrician's office that they received 1 hour of educational seminars and quarterly personalized feedback based off of data on their prescribing habits for upper respiratory tract infections. And what they saw was that compared to the control group, they saw a reduction in broad spectrum antibiotic prescribing for pediatric patients with URIs by 12.5%. And a reduction in off-label prescribing or off-guideline prescribing for pneumonia reduced by 75%. So it is effective, especially when you have data to be able to back who and why you are intervening. Clinical decision support. So we have to be a little careful with calling things clinical decision support anymore because AI is kind of taking over. And there's FDA regulations now on what's truly defined as CDS. But in this example, they show that CDS is highly effective at improving patient care and reducing inappropriate antibiotic prescribing. This is an approach that we know is hardwiring practice into patient care. At the point of care, the clinician, pharmacist, whoever will see that, hey, maybe you shouldn't prescribe this antibiotic for bronchitis, or this is the guideline recommended antibiotic or dose for a specific infection. And so hardwiring into practice is going to be great. It kind of aligns with what we've been doing for years in the inpatient space, but there's not a lot of CDS available, especially related to antimicrobial stewardship in the outpatient space. Of course, it does require leveraging technology, which is always the bane of our existence. But one example here is from a primary care stage intervention to reduce fluoroquinolones. They took several different interventions into the EHR. One of them being initial provider education, so that's not in the EHR, a warning message at the time of ordering, susceptibility report suppressing, so cascade reporting, and then an order set implementation. And what they showed was that after they implemented all of those interventions, there was a 39% decrease in fluoroquinolone prescribing. And that was mostly driven by the fact that they had clinical decision support at the point of care. And delayed prescribing. Now, this is one that we've all known about for a long time. It's very difficult to implement. And most of our EHRs or even the pharmacies that are receiving the prescriptions don't have a great way of operationalizing this. So with delayed prescribing, it does maintain patient satisfaction. The patient or the caregiver leave with a prescription in hand or a plan for them to be able to get the prescription if their symptoms don't improve. Now, they did do a systematic review / meta-analysis of 11 studies that demonstrated that delayed prescribing for respiratory tract infections led to a significant reduction. You can see the odds ratio there in antibiotic prescribing. But of course, we know the limitations again with operationalizing this. So if you're able to do it, it works well, but it can be very complicated. Here is a kind of smaller screenshot of what we did in our organization. We were lucky enough, and there's actually quite a few healthcare systems that participated in this, but we received grant funding from the Patient-Centered Outcomes Research Institute, or PCORI. You guys may have heard of them. They are funding pediatric antimicrobial stewardship in the outpatient space for reducing antibiotics or reducing broad spectrum antibiotic prescribing for upper respiratory tract infections in that population. So we received funding from them to kind of move this forward, which helps with the technology component, certainly. But what we implemented, this is Athena. Most of you probably don't have Athena. This is our outpatient EHR. Within Athena, we implemented these alerts that pop up on the right-hand side that give just real-time instructions to the clinician based off of the diagnosis and the antibiotic that was ordered. So they, within this EHR, have to select the diagnosis and then tag the antibiotic to it. And when they do that, if they selected acute bronchitis and then amoxicillin, it'll come up and say acute bronchitis is considered a viral infection, recommend avoiding antibiotics or changing your diagnosis. And so that has been very, very effective in reducing our antibiotic utilization. And I'll show you some data here in a minute. Additionally, on this slide, we analyze the amount of times in pediatric patients with URI encounters where an alert fired. And over time, actually, I don't have the stats here, but this is statistically significant reduction in alerts firing over time because clinicians were learning what they should do to avoid the alerts. So they may have prescribed amoxicillin for bronchitis that first time. They may have done it the second time, but by the third time, they're not doing that anymore. So this is permanently changing practice as well, which is really what we want to see from a sustainability standpoint. Tracking and reporting, this is going to be a component that is very critical. All of these are critical. Make sure the computer doesn't restart. All of these are critical in antimicrobial stewardship, but if you don't have data, you really don't know where to act. And it's really hard to convince clinicians that they have an opportunity or they're an outlier compared to their peers if you don't have data to show them. So it's going to be critically important to get data, to be able to analyze it, to normalize it, and then to report it out in a venue where there is a degree of accountability and there may be leaders there. You may have your antimicrobial stewardship champions there, but it's going to be important that these clinicians that probably in the outpatient space haven't been approached related to antimicrobial prescribing before, and now you're coming to them saying, you really probably should reduce your antibiotic prescribing or maybe stop using Cipro for UTIs. And they may say, who are you? Why are you here? So you need to be able to show them that they stand out amongst their peers. There's data that really is demonstrating that they have opportunity to improve. And this is an example or several examples of data that you can consider reporting out. We've started to do almost all of these in my organization. And of course, one of them being antimicrobial utilization. But you also want to look at the concordance with the diagnosis that was selected and whether the antibiotic was guideline concordant. Was that appropriate or not? Look at clinical outcomes. With the study that we looked at a couple slides ago, comparing control group versus patients with an intervention and broad spectrum antibiotic prescribing, they showed that patients did just as well with narrow spectrum antibiotic prescribing with less adverse drug reactions. So with your own patients, you're also going to want to demonstrate if we're avoiding antibiotics or using narrower spectrum antibiotics, are we detrimenting our patients or are they doing just as well? You want to be able to demonstrate that clinical outcomes are still not being affected by this, or hopefully even being improved. It's also important, and we've learned in the outpatient setting, it's important to be able to report at the system level, if you work at a system, market level, facility level, clinic level, or clinician level, and then by patient. Your outpatient clinicians want to know who did I mess up on? Or who are you saying that I could have improved my practices in? And if you can show them their patient cases where this was a patient that had acute bronchitis or acute pharyngitis, let's say, and they prescribed amoxicillin, but they didn't do a strep test or the strep test was negative, that's a great example to say, okay, next time could have avoided the amoxicillin, or if the strep test was positive, you need to document that as your diagnosis. So very, very specific patient cases tend to drive practice in the outpatient space. Now, we touched briefly before on the payer world, and in the acute care setting, we have Joint Commission that drives antimicrobial stewardship programs, which is excellent and really ensures that and also the Anthem scorecard, but it really ensures that we are compliant. Outpatient, you have Joint Commission, but not all of our outpatient clinics are actually Joint Commission certified, so it doesn't really apply to everyone. But what does typically apply to everyone are these payer-driven metrics. HEDIS is kind of, if you're familiar with that, they are the payer-driven metric kind of creators of the governance body that develops these metrics. And they span across many different disease states. What we're focusing on here are those that relate to antimicrobial stewardship. So payers have picked up on the fact that stewardship is critically important, and they have us reporting on antibiotic prescribing for bronchitis, on whether strep was tested for in patients that were prescribed an antibiotic for strep pharyngitis. And additionally, this newer measure from 2023 looks at all respiratory tract infections across the spectrum and the percentage of antibiotic prescribing for those diagnoses. And what's nice about these payer-driven metrics is they're monitoring you. You want to perform well, but also they give you external comparators to see if you are within the 50th percentile of prescribing habits, or how are you doing compared to any other organization that is reporting these measures to that payer. So generally, you have quite a few external comparators that you can compare yourself to when it comes to these measures. So payers do drive practice and stewardship in the outpatient space as well. This is our data. Wanted to show you with the interventions that we've made with pediatric upper respiratory infections with this PCORI grant. We've done basically all of what I've just shared with you today. And over time, we've seen a significant reduction in antibiotic prescribing for viral infections. So we went from 7.1% to 5.5%. And really our target when we started off this initiative was to reduce below that teal dotted line. And we've already achieved that goal. So this can be very effective, but it takes the holistic approach. You need to have all of these critically important core elements, 4 and now 7, in place to be able to drive this forward. And here is also a diagnosis-specific measure looking at broad spectrum prescribing for acute otitis media in pediatric patients. Amoxicillin clavulanate is used all the time, but you can get away with amoxicillin really up front. You should be using amoxicillin as your primary therapy, unless patients have failed or have other risk factors. Our antibiotic use for our broad spectrum antibiotic use for this population reduced by an absolute percentage reduction by 2%. And so we're not quite at our goal yet, down at that green dotted line, but we're getting close. So you can do it. What we were sharing though before was that data needs to be able to be very granular. You need to be able to share which patients you could have acted on differently to have curbed your prescribing practices. And you also need to be able to drill down by clinician. Now I've blocked out the clinicians' names here, but this is our clinician scorecard. You can see each clinician would be named here, and we can actually see the names. Their leaders can see the names by highest opportunity to lowest opportunity. And we've stratified by excess events. How many antibiotics or encounters that they prescribed an antibiotic for need to be cut back on for them to be at their peer average. So this is all normalized and front and center for our clinicians. They know if they're at the top of this list, and they have their leaders following up with them saying, hey, this is a priority for the organization. These are your patients where you could have done better. And we're seeing this really start to curve to the antibiotic utilization in the right direction. So with tracking and reporting, it's important that you start out with data that's readily available. Not all of us have a nice database that you can pull from. Some of us are literally just using Excel sheets and reports that come from your EHR. Others may have Tableau or other programs that are similar to it. And so start with data that you have readily available to you, validate it. The worst thing that can happen is you go to your clinicians or you go to your staff and say, here's the data. They question you, and turns out the data was wrong. Then they're not going to want to hear from you for a while again until you revalidate your data. So we've learned that the hard way. Make sure you validate your data. Collaborate closely with your data analytics teams. You don't want to have to be doing all the data analytics yourself if you can avoid it. And then determine the best strategy for reporting out. Who are you going to report to? What's that accountability structure? Who is going to keep these prescribers in line if they find that they have opportunity? And then use benchmarks. We stratified our clinicians by their peers, but you can also look at the payer-driven metrics to see how you're performing. Obviously, inpatient, we have AU and AR. We don't have that outpatient, but at least the payers are starting to catch up with reporting out on those specific measures that we talked about earlier. Now, I only have a few minutes left. I do want to hit on education and expertise, and then we'll be able to wrap up here. But education is going to be critically important in the outpatient space. It's different than the inpatient space. You're not just educating clinicians, prescribers, pharmacists, nurses. You are educating the patients. Patients drive antibiotic prescribing in the outpatient space. They come in, parent comes in, kid's sick, they think they should get an antibiotic. Again, they probably leave with an antibiotic. So how do you level set with your clinicians on how to approach patients, the psychosocial behaviors they need to have to be effective clinicians, effective stewards, and also how can they consult experts? Who can they go to if they have questions on what they're supposed to prescribe, how they should be talking to patients? So with that, this is important to consider because in the outpatient space, if your patients are determining their care, you need to understand that if they come in thinking they're going to get an antibiotic, they may leave with an antibiotic. So how do you have those critical conversations with them and still provide that value that they're expecting you to provide? So data has shown that patients that have a higher expectation of receiving the antibiotic for their infection tend to have lower healthcare literacy and oftentimes are non-English speakers. But they've also shown that lower expectations for antibiotic prescribing is not associated with dissatisfaction. So if a patient thinks they're not going to get an antibiotic and they still don't get an antibiotic, they're not dissatisfied. So patients typically are going to be okay with whatever you decide to prescribe as long as they feel like they were involved with their care and understand why they received the care that they received. So the CDC has some great tools that they can use or that you can use to help educate patients, show them what's viral, what's not. The example here on the right is actually what we've found from our patient families. We've done engagement seminars with our patients, and they have voiced that they want this viral illness symptom pad to go home with. The clinicians can write on it and say, you're not getting an antibiotic, but you can do nasal saline sprays. You can do humidifiers. And then they have something in hand that was written down. They can go home with that. It's not an antibiotic prescription, but they have guidance on what they can do for when they get home. And they felt satisfied with that. The DART program is one that I just want to point out here. This is a great reference. This has been presented at ID Week, at SHEA. These are specific instructions on how to talk to your patients. We've seen this in the vaccines lecture earlier, but if you are more intentional with your language, then patients are going to trust you more, and you're more likely to get through to them what you want to convey. And then finally, here with the education section, there was a Cochrane review looking at a meta-analysis of 10 published studies, 492,000 primary care patients, and they showed that shared decision-making reduced antibiotic prescribing significantly from 47% to 29%. Number needed to treat was 6 patients, that's it. And patient satisfaction was not affected. So shared decision-making outpatient space is huge. We don't feel that as much inpatient. Outpatient is critically important. This is what we developed for shared decision making with this grant. We found that patient satisfaction, so I'll just kind of flipping ahead here, patient satisfaction, whether they got an antibiotic or not, is listed here. 286 parents were surveyed after their kid was seen for URI. And if they got an antibiotic and had the decision aid, shared decision making was used, 100% were satisfied. If they didn't have the shared decision making tool used, 85% were satisfied. But we saw greater satisfaction with the decision aid being used and no antibiotic prescribed than the prior one, no decision aid used, and they still walked home with an antibiotic. So feeling like you are engaged with your clinician and they are helping you understand why you're getting the care that you are, and you feel like, hey, I'm not getting an antibiotic because we discussed this, and now I feel confident about this decision, then patients are very satisfied going home, and they probably got the right care that the clinician intended. So that brings us to our final steps. There are a few things that you can do right now. And this is for everyone who works in a healthcare practice or not, but you can conduct a needs assessment. Where are your opportunities? How can we start collecting data to determine where we can make improvements? Build a financial model. So whether that's just looking at the payer-driven metrics and how that may penalize some of your practices, or whether there are truly cost savings with reducing antibiotic use or testing in the outpatient space. Define your metrics for success. What are you going to track? What are you going to report out on? What is your C-suite going to care about? What is your antimicrobial stewardship program going to care about? And then rally the troops. Engage your stakeholders. You can't do this by yourself. One person shouting to the crowd is not going to be effective. So make sure that you have clinicians on your side, pharmacists on your side. Get the whole team on your side before you start to try to move this forward, because you're going to be much more effective if you do so. And I had this slide before the new core elements were released, but additional outpatient opportunities that necessitate antimicrobial stewardship programs are listed here. Dentistry, skilled nursing facilities, etc. A lot of these areas really haven't been addressed. Telemedicine was just discussed in the prior session, but now the new core elements that were released this week do address the majority of these spaces. So that was a huge gap that they've now filled. And with that, I think that butted up to the very last minute. So I'll take any questions if there's time.
Thanks, Dr. Cosimi. That was great. Are there any questions? Well, I have a couple.
So you said that you use Athena. How were you guys able to pull the data?
Good question.
Repeat the questions for the.
Yes. So question was, we use Athena in my healthcare system, and how are we able to pull the data? So we're lucky. We actually have a large data analytics team that will pull the data into a data warehouse, and then we're able to then harmonize that and analyze it within Tableau. Power MD is also one, or Power BM, I've misquoted that, but that's another one that many healthcare systems have, but others oftentimes don't have reports like that. What I will say is many of the outpatient EHRs do have these payer-driven metrics built within them. And so you can see compliance. Clinicians can actually see their own compliance with, for example, antibiotic prescribing for bronchitis within the EHRs, but it's just a tool that needs to actually be activated in order for you to see it. Yes.
For your provider work card that you were talking about, I'm assuming that they only see what they're doing and it's compared to people within their section or peer providers. How is that communicated to them by your stewardship team, or is it only communicated by theirs?
Great question. So current structure is that we have a governing group committee that will have ongoing, right now it's monthly calls with the leaders in the markets and the clinic leaders. That will, in the sustainability phase, extend to quarterly meetings with them. But we will share their opportunities, so their high opportunity clinicians with them, the unblinded version of that slide, and then they go forth as the local leaders to have those direct feedback conversations with their clinicians. Good question. I didn't repeat the question, but yeah. Yes.
So you talked about the importance of engaging C-suite leaders in making these decisions, in supporting them in signing a document, committing to them. I've seen that discussed a few times. You also discussed how it's important to be dogged in your approach and maybe to approach a number of times and then they've heard it a few times and have time to buy in. Do you have any other tips on bringing leadership on board to a system-wide approach? Do you have to make a financial pitch or what are other avenues you could pursue?
Yeah, absolutely. So financial pitch is always going to be actually question being how to pull in the leaders and get them to buy in on antimicrobial stewardship programs in the outpatient space. It's difficult. You oftentimes need to get either a leader that has a passion for stewardship if you are not going to be able to make some sort of regulatory or financial pitch to them. From the standpoint of convincing them that this is the clinically correct thing to do, I do think that there is value in creating maybe slides like this to show how many antibiotics are prescribed, the proportion of antibiotics that are prescribed in the outpatient space compared to inpatient space, and how this is contributing to the global health issues. But oftentimes, if you're going to try to snag the ear of your leaders, you need to have some sort of financial or regulatory component, which is why having the payers actually participate and engage the clinics in their stewardship practices is actually a great step in the right direction because that will help with driving antimicrobial stewardship in the outpatient space.
Right. Another question. I'm a different type of provider. I'm a veterinary provider.
Nice, yeah.
But we deal with similar issues, right? You bring the dog to the vet, it's sick. That's already annoying. You're having a bad day. You want to go home with an antibiotic, right? So it's just as difficult on the veterinary side. I wonder if you have any other tips about you mentioned the importance of understanding psychosocial behaviors. I've heard people suggest phrases like, because I'm looking to protect your health, I'm not going to prescribe an antibiotic, or because I'm worried about your family's health. Do you have other communication tools about how to, in interpersonal communication, how to try to manage expectations about prescribing?
Yeah. One of the things that I've seen to be very effective in that space is either having a whiteboard in the office to be able to show what's the difference between a bacteria and a virus or where your symptoms are actually coming from. The other thing that a lot of our clinics have started to use are patient point screens that are just televisions in the room that you can go in and click on the disease state, and it shows them videos, it shows them education on anything that you want. And we've actually, in our family medicine and pediatrician offices, put those at the level of the kid. So they're actually down close to the ground so the kid can see it and understand as well, like what's going on, why they feel the way they do, and also whether they're going to get an antibiotic or not. So we found that is actually a very useful way to leverage new technology to help patients better understand their care.
Yeah, that's nifty. Cool.
Yeah.
Piggybacking off that, I feel like we've been trying to dip into the outpatient setting as well, and like that's been one of the biggest challenges with when we talk to some of the outpatient providers, they have said, well, it's a transactional appointment, like they're coming in, they're expecting something, so it's like how do we avoid that and how do we overcome that? So some of the tactics that they had recommended, and that made sense to me afterwards after we talked about it, was like, okay, I won't give them an antibiotic prescription, but I'll give them a prescription for ibuprofen. Yeah, it's over the counter, but it's something that they're getting, like a piece of paper that they can take with you. And when I would get that at the pharmacy, like, why are we filling ibuprofen if you can get it over the counter? But it's like that mental kind of like, I'm getting something transactionally and then I can go and fill it in afterwards. So that's some of the strategies that they would use that they felt that were helpful. But again, in that medicine, like that's everything is not over the counter, but yeah.
Yeah, similar approaches, probiotics,
Yeah.
diets, saline rinses, something to do.
They want something.
Symptomatic treatment.
Absolutely. And we're actually hearing that even more in probably vet offices, but urgent care, emergency medicine. When you go into your pediatrician's office, oftentimes it's covered by insurance. But if you're paying $100,000, $100 or $1,000, not $100,000 for whatever appointment you're going to with the urgent care, you expect to leave with something in hand. And if you don't, then you're not satisfied. So I think that's a very good point.
All right, well, thank you, Dr. Cosimi.
Thank you.
Great. Appreciate it. All right, I think there's a 10-minute break now, and then a new round of talks.